right, everyone, welcome. Today, we're going to tackle a really fascinating and, more importantly, a super high-yield topic for your exams, the strange world of slow neurodegenerative infections. Let's just dive right in.
So here's our game plan for today. We're going to start with the basics of what makes a disease slow. Then we'll cover two major slow viruses you have to know, PML and SSPE. After that, we're jumping into the truly weird world of prions, the diseases they cause, and we'll finish up with the critical must-know points on diagnosis and sterilization. First things first, what does it even mean when we call a neurodegenerative disease slow? Okay, so the core definition is right there. We're talking about a crazy long incubation period, months, sometimes even decades, followed by a 100% fatal outcome. And the word slow isn't just about the timeline, it's about the pathogen itself. These things can have a replication or doubling time of over 5 days. That's what really drives this gradual, creeping onset of disease. Now, for your exams, you've got to have a way to remember this stuff. So here it is, a fantastic mnemonic. Just think of the word link. L for a long incubation period. I for an invariably fatal outcome. N for no significant immune response. And this is a huge clue, right? The body doesn't even seem to see the threat. And C because the central nervous system is ground zero. So burn link into your memory. It's going to help you out.
All right, let's get into our first specific disease, progressive multifocal leukoencephalopathy. We'll just call it PML. This is one of those classic associations you just have to memorize. PML is caused by the JC virus. And a fun fact, it's named after the first patient it was identified in, a guy named John Cunningham. What this virus does is it attacks and destroys oligodendrocytes. Remember, those are the cells that make myelin, which is basically the insulation for the neurons in your brain. So you get this widespread demyelination. It's like stripping the wires in the brain's electrical system. So who gets this? The number one thing to remember about PML is that it's an opportunistic infection. If you see a test question about a patient with HIV/AIDS who suddenly develops new neurological symptoms, like they can't see properly, they're confused, they're weak, PML needs to be shooting to the top of your differential diagnosis. Honestly, over 80% of cases are in people who are immunocompromised. It is a hallmark of severe immune failure. For diagnosis, an MRI is going to show you those characteristic lesions in the white matter. But your absolute gold standard test, the one that gives you the definitive answer, is a PCR on the cerebrospinal fluid to find that JC virus DNA. Now, for treatment, there isn't really a direct antiviral for this. So the entire strategy is about one thing, restoring the patient's immune system. In an HIV patient, that means hitting them hard with antiretroviral therapy to get their immune function back up. Okay, on to our second slow virus disease. And this one is a truly devastating complication of a childhood illness we all know about. It's called subacute sclerosing panencephalitis, or SSPE. Now, this is a super important concept to get right. SSPE is not the regular measles you get as a kid. This is a very rare, super delayed complication where a defective version of the measles virus hides out in the central nervous system for years, just smoldering away, slowly causing progressive and totally irreversible brain damage.
So your classic board exam question is going to look something like this. A teenager or a young adult shows up with declining school performance, maybe some weird jerking movements called myoclonus, and when you dig into their history, they had measles when they were a toddler. That massive delay, 7 to 13 years, is the defining feature. And once the symptoms start, it's tragically fast. Death usually occurs within 1 to 3 years. When it comes to diagnosis, the single most important lab finding, the one you've got to look for, is ridiculously high levels of measles antibodies right there in the cerebrospinal fluid. That tells you the body is mounting this huge immune response inside the central nervous system, but it's just not working. That finding is the key to diagnosing SSPE. And as you can see, tragically, there is no effective treatment for this.
So we've covered the slow viruses. Now let's get into something even stranger, something that completely breaks the rules. Let's talk about infectious proteins.
I mean, think about this question. What if an infectious agent had no genetic material? No DNA, no RNA? It sounds impossible, right? Well, answering this question won Stanley Prusiner a Nobel Prize. It completely shattered the central dogma of microbiology. The answer he found was the prion, a proteinaceous infectious particle. That's where the name comes from, an infectious agent made of nothing but protein.
This table is everything. If you understand this, you understand prions. On the left,
you've got PrP cellular, or PrPSc. That's the good guy. It's a normal protein in our neurons, and its structure is mostly alpha helices. On the right, you have the bad guy, PrP scrapie, or PrPS. It's the exact same protein, but it has misfolded into a beta-pleated sheet structure. Now look at the key difference this causes. This new shape makes it resistant to proteases, the enzymes that are supposed to clean up old proteins. So while the normal guy gets recycled in hours, the misfolded scrapie form sticks around for days, and it just builds up and becomes toxic.
And this slide shows you the terrifying result. It's a chain reaction. One bad PrP scrapie protein acts like a template. It bumps into a normal PrP cellular protein and forces it to misfold into the bad shape. Now you have 2 bad ones, then 4, then 8. It's exponential. These misfolded proteins clump together into these amyloid plaques. The poor neurons try to clean them up by internalizing them, and this process leads to these vacuoles, these holes forming inside the neuron. Eventually, this is what gives the brain that classic spongiform or sponge-like appearance on a biopsy.
So what does this look like in actual human beings? Well, the most common prion disease you're going to hear about is Creutzfeldt-Jakob disease, or CJD.
Okay, listen up. This table is absolute exam gold. You have to know these 4 types of CJD, no excuses. Sporadic is the most common. It's just random. Bad luck, a protein misfolds for no reason. Familial is genetic. You inherit a faulty gene for the prion protein. Iatrogenic means it was caused by a medical procedure. Think contaminated surgical tools, corneal transplants, things like that. And finally, you have variant CJD. This is the one you get from eating beef contaminated with bovine spongiform encephalopathy, better known as mad cow disease. The biggest clue for variant CJD is that it hits a much, much younger crowd. Okay, let's wrap this up with the super high yield points on how we diagnose these things and the massive, massive problem of how to get rid of them. So, while a brain biopsy that shows that spongy change is a key finding, your definitive diagnostic tool is an immunoassay that is specifically designed to detect the bad guy, the misfolded PrP scrapie protein. And don't forget that classic finding on an EEG in the late stages of the disease, these high voltage, triphasic sharp wave discharges. They're very characteristic.
Now for a clinical point that is so important it could save lives. Prions are not like bacteria or viruses. They are, and I mean this, unbelievably resistant to normal sterilization. The stuff you use every day in a hospital, disinfectants, even a standard autoclave cycle, it just won't work on them. These proteins are incredibly stable.
You need to memorize these numbers. Seriously. These are the specific extreme protocols you have to use for prion decontamination. A standard autoclave runs at 121 degrees Celsius. For prions, you have to crank it up to 134 degrees for at least an hour. Your other options are soaking the instruments in 1 normal sodium hydroxide for an hour or in concentrated bleach for 2 hours. Anything less than this is not going to be effective. And that leaves us with a really tough question for modern medicine, doesn't it? When you have an agent that resists sterilization, has no cure, and can be carried silently for decades, how do we protect our patients from accidental transmission? Understanding these unique and truly formidable pathogens is absolutely essential, not just to crush your microbiology exams, but for being a safe and responsible clinician for your entire career. Thanks so much for tuning in.